Thank you, Dr. Donnelly. That was fantastic. Now we'll transition to our second talk of the evening. This is Dr. John Burleson, a spine surgeon in Nashville, and he's going to talk about 10 factors to consider when choosing a job.
John, I think you're still muted. I think you're still muted.
Thanks. Couldn't agree more with what Dr. Donnelly was saying. I think if you guys don't follow him on Instagram, he had his little hashtag on there. We'll throw that up again at the end. But anyway, he presents a lot of cases that are super challenging and interesting. And if you want to sharpen your skills a little bit, I encourage you to do that. Anyway, so I'm going to talk about 10 factors to consider when you're ready to choose a job. I'll tell you just real briefly about myself here. So I grew up in the Dallas area, went to med school down in Houston, did my residency up in the north. Unlike what Dr. Donnelly was saying, I spent 6 years in the frozen north. That was an experience. Went back down to Dallas for fellowship. Now I'm in practice in Nashville. I'm in a group of 20 orthopedists. I'm one of 2 spine surgeons. Currently working on getting some more up there. Got 2 kids, married, and I have another kid coming in April. All 3 boys. So they're locked in the basement right now, so that's not too loud in the background. My wife is there with them. And then I'm really interested in kind of new technology stuff. And as disclosure, I consult for a few device companies that is not really relevant to this talk. I'll go to the first thing. So most important thing is these are not in any real order, just in order that I kind of thought of and tried to make them flow well. But there's a ton of factors to think about. I got the same disclosure that Dr. Donnelly had that, you know, this is my experience and what I went through. Now, I like to think I was pretty attentive to what other people were dealing with. I interviewed for my first job when I was like halfway through my chief year, so I really tried to start early. I don't think that's necessary for everyone, but I'm going to talk about some of the things that inform my decision and that hopefully everyone's thinking about for theirs. So first thing is location. Unlike fellowship, I'm a big believer in picking the place you want to be. There's a concept known as kind of a financial fellowship, like you go work in Alaska for a couple years and make a bunch of money and then move somewhere else. Although that's not impossible to do. For me, I didn't really want to go somewhere that was looking for a long-term fix and then leave after 2 years. I didn't want to move my family and relocate again. So I'm kind of a believer in going where you think it's going to work. So if it's somewhere new, it'd be nice to have a busy airport so you can visit your family and friends if they aren't at that location. You need to consider the cost of living. Things like the public schools and stuff are really important. Even if you don't have kids, that's going to mean retained value in the house that you buy. Figure out if you want to do the city versus the rural thing. I mean, I'm biased, but I think being in a big city that has nice suburbs gives you the option of transitioning without leaving your practice. If you think you're always going to live in the city and then you have 3 kids, let me tell you, that might be difficult to continue long term. So you might want to consider that. And then compensation, which I'll kind of talk about at the end, obviously matters a little bit too. In different locations, they pay different amounts. And as you guys are probably aware, groups and practices vary, but largely the more expensive cities pay less than some of the more rural areas. So that's kind of a double hit if you're in a really dense city. And it might be worth it for you and your family, but you should think about that. Next thing is the employment model. There's a ton of different models. Obviously, there's academics, which we talked about, might allow you to do more research. You can do it in private practice, but obviously academics tends to be more streamlined in general. They're going to have access to residents and fellows in many cases, and that can be a big plus. Allows you to teach and allows you to have people that keep you young 30 years down the road, and also allows you to have people that will do some work for you. As every resident out there knows, you're doing a lot of work that the attending doesn't have to do. Private practice is an option. You can be in an orthopedics practice or a neurosurgery practice if you're a neurosurgeon, or you can be in a spine-only group. So like Dr. Webb is a spine-only group and I'm in an ortho group. We did the same fellowship and had a similar experience, but our experience out is a little different. There are pluses and minuses to all of that. You might get more internal referrals in an ortho group, but you certainly have more backup and more help in terms of the OR and how you think through things if it's a group that has multiple spine surgeons. You can also do a multi-specialty group, not quite as common in orthopedics, but there are a lot of larger groups that employ physicians that might have orthopedics and more pain management and more, non-op ortho, maybe even other surgical specialties like access surgeons or vascular surgeons. You can also be employed by the hospital directly. Potentially that could be a higher dollar amount the first couple of years. That was certainly my experience in talking to some of those hospitals. They kind of throw out a number that can seem irresistible. Keep in mind that typically comes with less autonomy, and there's the potential that you're selling your soul and selling off your specialty. And I know that sounds harsh, but ask the hospitalists how that's gone in general. And although some of them might enjoy their career, the autonomy hit can be really big. And as a spine surgeon, you've worked really hard to be able to do the best thing for your patients. I don't know that I would deal well with the hospital telling me that I can't do these 3 things that I want to do. But at least think about it. It might be the right answer for you, but you need to know what you're getting with that. You need to think about your partners. Obviously, the size of the group matters. You can be in academic departments, and they can be huge. Really large private group or a small private group with just 1 office and 4 guys. These are people that you're going to spend time around. And if he or she is a normal person, great. But if they're not, you have to keep that in mind, especially if you don't have residents. These are going to be the other people that you're kind of seeing the most. The age of your partners is tremendously important. If you're coming right out and you got a bunch of partners and they say, well, we got 5 spine surgeons and you're going to be the 6th one and all 5 of them are over 60. Well, they have a lot of knowledge for you, but they might not be there in a few years. And that could really put yourself in a precarious situation. So at the same time, if they got 4 or 5 partners and one of them's retiring and you're kind of taking that spot, that might be phenomenal. You might be getting those referrals from the community, and that can be really helpful. Having younger partners can be nice just for the fact that they might be more relatable for you. So that can also be an attractive thing. In terms of the practice with your partners, one of the things you need to think about is if you have multiple other spine partners, is this just built-in competition? You need to at least think about that. Are you working in the same area as them? In which case, their business is your business, and it might be a little bit of a zero-sum game. That's normally not totally the case. You can always kind of expand your bubble, but it's a little different if you have 10 ortho partners that don't do spine and are looking for someone to send their spine patients to. And then if you're also in a practice with other spine surgeons, is how similar is your practice? Are you wanting to do kind of boutique spine stuff and they're wanting to do deformity? Are you guys wanting to do deformity together and scrub some cases or at least assist on small things? I mean, all those things kind of matter, but those are questions you should be asking the group. How do they see you fitting into that puzzle? The culture, super, super, super important. Are your partners people you want to be associated with? Whether you like it or not, people typically refer to practices. When you get a really big name, sure, they might send you to Vaquero because he's a huge name, but a lot of times they're referring to the practice and then the patient gets routed to you. Well, if your practice has surgeons that are doing a bunch of non-evidence-based stuff or some kind of shady procedures, that's going to make you look bad. So you really have to think about that. On the academic side of things, it's very common for people to refer to a university because the university has prestige, and that can help you early on because you're a new professor, assistant professor, associate professor at this university. That can be a really big positive. You want to know if there's a lot of turnover in the group. If they keep getting docs that are there for 2 years and leaving and 2 years and leaving, that's probably a good sign that once their guarantee salary or base salary runs out, either the pay's not good enough and that's dropping off and they're wanting to leave, or there's major conflicts within the group. So you really need to know what the pattern has been. Are they continuing to grow and adding people? Are they losing a lot of people? It's super important. And then what I put here is, how do they retain people? Do they retain people with fear by having some restrictive covenant that basically makes it impossible to practice, has a buyout of $500,000, that makes it where people can't leave? Or are they retaining people because they make it a practice people want to be a part of? They make it where the buy-in and buyout are fair and people are staying because they want to be in that group. So, you can always ask the younger partners about how that process went for them and if they are seeing themselves staying. And if you see the whole group staying for 10 years apiece plus, that's a positive thing. So another thing you have to consider is the level of control that you're going to have in your practice. So this really varies heavily from academic to private, but within private groups, it varies as well. So if you're in a group with just a few docs, you're going to be the one that decides whether you want an MA or a nurse, and if you want to hire a nurse practitioner or a PA. And I'll tell you, as someone who's in that situation now, The answer to hire an NP or a PA is solely yours. I mean, the financial people will say, well, here's when we think the numbers make sense, but that's on you. And you're going to do the interview and you're going to hire someone and you're going to train them. And that sounds awesome. But if they suck, then you got to fire them. And I don't know about you guys, but I haven't fired a lot of people and I'm not planning on it in the near future. But if that happens, that's not fun for anyone. If you're in a really large group, maybe their HR people will take care of that. If you're at an academic center, obviously you're not having to do that. So it's at least something to consider. With the level of control comes the responsibility of being in control. Your clinic schedule, your OR schedule, all those things vary in terms of control. So you need to be asking that during your interview. Can I pick the days that I'm where I am? Academic days, super helpful, especially in an academic setting, obviously, but do you have protected time for research? Is there a way for you to get in a position of leadership, like eventually move into a residency directorship? And what's the pathway for that? You need that to be pretty clearly outlined for you. If you don't talk about needing an academic day, you're not going to get one. So those things need to come up in your conversation. If it's private practice, you need to talk about regular time off. It might not be an academic day, but it might be, hey, my son's got T-ball on Thursdays. I'm covering my overhead costs. I'm making the money. Like, I want to take Thursday afternoons off. And that should be something you can control if you're in a smaller group. Hospital affiliations. This goes on the list of things I never thought about when I was in training, because you just go where you go. I trained at UMass, so I went to the UMass hospitals. Well, if you're going to private practice, you can kind of choose. Like, my group works at like 7 different hospitals. I don't. I work at 1.5. I mean, I round at 1. The other one in my clinic is at the hospital because that's what I wanted. I didn't want to be driving across town and rounding at multiple locations all the time. So that's something, again, you can ask about. It's not the only thing that matters for a job, but it does affect your quality of life. If you're operating at one hospital mainly, you get to meet the staff. You can have the same crew with you. You know, those types of things are valuable. And then stuff I put on here because, again, I went to, like, you know, blue collar residency program. Like, first time I walked into a doctor's lounge and they had booths for dictation. They have the little thing with ice cream over there. You just eat as much as you want. Like, it's incredible. I mean, I wouldn't recommend doing that, but you can. It's awesome. Things like that are helpful for quality of life. You know, it's if you have to be at work, you might as well be happy while you're there. Is the group focused on growing? Is the hospital in this case focused on growing? Are they going to buy navigation and robotics if they don't have it? If you need that, are they going to buy that? Are they adding on to the hospital? Do they have an aggressive growth plan? Or are you seeing other hospitals in the city bypassing that? And you can only figure that out if you're new there by asking the docs. But they will tell you that this place is dying or this place is growing or people are getting out. You need to know about that before you sign up. And then in terms of the hospital logistics, go to the OR board and see what the schedule is for the day. If there's a spine surgeon on the board that's doing 5 cases in 2 rooms and they're done at 4 o'clock, that doesn't mean you need to be that fast, but it means the OR turnover is. It means they're staffing them appropriately. It means that the limiting factor for the surgeon is the surgeon. That's what you want. You want to be the limiting factor. When you train, there's a billion things that are the limiting factors. I mean, we had 2-hour turnover times all the time because, well, it was a break. And we had 4 different breaks for the scrub during that case. And the second one only does heart cases. And this is his first surgery on the spine. You know, we dealt with all that stuff. That's just part of training. When you get out and you're picking your job, that's one more thing you get to play with. That's another variable. So you should take a look at the OR and see how it runs. Does it run like a surgery center or does it run like a level 1 trauma center? It's okay if it runs like a level 1 trauma center. You just need to know that, because if you're not someone that deals with stress well, if you like to throw things when you get frustrated, maybe don't take that job, because that's not going to go well for you or the HR department. And then the other thing you need to consider is a surgery center, as I just kind of mentioned. Is that an option? Another thing we don't think about in training all the time is diversifying income streams. And we're going to have some other conversations on that throughout the course of this series. But, you know, having investments in things like a surgery center and a place you can operate in and make some extra money on the side as being a part owner is something you should consider if the state allows that where you are. Then this is a thing that I think is super important that I did not care enough about early on in the process. And that is, are you trying to reinvent the wheel? Are you, going to a group that says, we got 3 sports guys and we really want to add spine because we've heard that you guys make a lot of money and we're really hoping to share some of our overhead. But that, by the way, is a terrible selling point, and please make sure that's not happening. But the reason why I bring this up is because you want a group that's doing a lot of the things already. You want a group with a marketing team, and if that's an academic center, they have that. They have the resources for that. You just might need to direct them a little bit. If it's a private group, it's really helpful if they have a marketing department that can take you around to meet the pain doctors and meet the primary care doctors, and maybe even meet some of the other orthopedic surgeons that don't have a spine guy or girl in their group, so that they have someone to refer to. So it's really helpful. Otherwise, you're literally Googling addresses and trying to find out where these doctors are, so that you can go shake their hands, or I guess in today's day and age, you wave at them or elbow bump or whatever. But that was a really helpful thing for me. The other step of that is having a little bit of a budget to do things like a little TV promo, or can we make digital ads, and things that can help get me out there on social media through my own accounts or through their accounts. Are they going to build out your website the way that you want, where it looks professional? Are they going to make it easy for patients to rate you when they have a good experience, so that ultimately, when you have a patient with a bad experience because they wanted, Dilaudid and you didn't give it to them, and they give you a 1-star review on every website, you want to be able to have a bunch of 5-star reviews on there too. So those are things that they should be thinking about while you're thinking about being a spine surgeon. So having those processes in place are really important. And then I kind of mentioned this earlier in terms of reinventing the wheel with the hospital, but you really want to go to a hospital that's doing some spine surgery. Again, I know that a lot of you guys at residency fellowship, like, you're kind of starting to get the cases down. Trust me, there's an illusion of control and standardization when you're in training. When you get out, it's not necessarily how it is. And if you have to be the person to tell someone what a Jackson table is, or explain to them what a Kerrison is, or why you might need a Kerrison, or that should or shouldn't be in the cervical or lumbar set, or you go like some of my buddies, one of my buddies in Alaska, and he did his first spine case up there. They didn't have any lumbar retractors, and they had one cerebellar. His patient was 300 pounds. So like, that's not a great way to start. So if the hospital is already doing spine surgery, then you can go there and focus on just being good as a spine surgeon, which is the most important thing about being a surgeon, is being good at it. So you don't want to have too many balls in the air. And if they're already doing some spine surgery, they already have the sets. Worst case scenario, when they ask you, what do you want for your ACJ? You can just say, just give me what Dr. Blank uses, and we'll build my card off of that. So it's nice to have some of that already in place. Another thing frequently forgotten, can't get through the contract stuff without talking about it and bringing it up. And it's not really fun for us to work through, but it's super important, is the benefits. So this is an area where a lot of the academic centers really shine, because they typically have a lot of this stuff outlined. But you want a 401k or 403 or whatever the equivalent is. It's obviously nice if they provide a match. We'll talk more about that in a second. Health insurance. Let me just tell you guys right now, if you're going to pay for your health insurance in a private group where you're the employer and the employee, you're going to have some serious sticker shock, because the numbers are super high. But let me just explain that unless they're buying it at a super great rate, typically what's going on is your employer's paying part of that, right? They're paying the other side. If your employer is paying the other side and you're a doctor that works in a doctor's group, your employer is getting that money from you and from all the other doctors. And chances are they aren't returning it one-to-one, because they can use it for other things, or to pay the partners if you're not a partner yet. So it might actually be more expensive for you to only pay part of it, if that makes sense. And we can talk more about that later. If people have questions, please ask them. HSAs, phenomenal thing to have. I could talk all day about HSAs. They're the best investment out there. It's triple tax advantage. You're paying, you're basically able to put in money pre-tax that's not going to get taxed and is going to grow tax-free, and don't even deduct your health expenses against it. Again, ask questions, contact me. Love to tell you about HSAs. They're like the best thing ever. And they don't phase out based on how much money you make like a Roth does. Do you have a pension? Obviously, that's not the case in private practices. In academia, it absolutely can be, and that can be super valuable. So you obviously want to look into that in addition to your other retirement savings options. A huge thing that I wish every private group had, but none of them have, is childcare. If you have kids, you know how expensive that can be. I mean, I got 2 kids in a moderately priced city. I pay $3,000 a month. There are plenty of places that have on-site childcare as a perk for the employees of the hospital, either for free or for much cheaper, or for just the fact that it's open at 6 a.m. and you can drop your kids off and you get to work. Like, that alone is massive. So those types of things are great. Free meals in the hospital kind of goes with the doctor's lounge. I mean, it absolutely adds up, and it makes you feel special because you get a free meal every day. It's awesome. And then little things in the office, like, are you buying your own computer? Like in my office, my practice is a piece of paper, right? So I'm bringing in all the money and I control where all of it goes. So I have some overhead I have to pay, of course, but if I want a dual screen monitor, I'm buying the dual screen monitor. So when you start up, that can be aggressive cost wise, but in the future, when we bring in other partners, I'm not paying for that partner that wants a brand new iMac, like that's on them. So in my opinion, that's okay, because at the startup, I'm used to living like a resident. So I don't miss a little bit of that money that's going towards the equipment. Number 9 here, contract stuff. Again, like, geez, we could have a whole talk about contracts. It's super important to know what you're looking at. It's super important to actually read this. This is not like the Facebook terms of service where you just click yes and then they sell all your information. This is like, you have to read this thing, and things you don't understand, you need to ask about. And then before you sign it, you need to spend the money, real money, spend $1,500, whatever. It's the best money you've ever spent on a contract attorney that does physician contracts. If you need a name, I got a great name for you, but it is like super important. The whole thing here, you got to keep in mind, is this is the best the relationship's ever going to be when you get there and everyone's trying to court you. And so if things go bad, you want to make sure you're protected. So just briefly to hit on a few things. Restrictive covenants matter. Know what that means. Know what the proximity is. It's basically saying that you can't practice with another group in this area if things fall apart for whatever reason. You need to understand what the buyout is. Sometimes they'll say, here's the area you can't practice within, but if you pay $100,000 or $200,000 or something, then this goes away. Know what that means. You know, if you live in LA and your wife's family's in LA and you're a guy married or a girl married and that's where you want to be, and they give you a restricted covenant at 30 miles, if that doesn't work out, you really can't live in LA anymore. And the implications of that obviously are massive. So just think about that before you sign those. Termination, there's always going to be that in there. The right to terminate with and without cause. You want to make sure you have, these are super easy things to put in that are not going to be there by default. One of them is have the right to cure, which means if a nurse says that I made her feel sad and that I should be fired for that, and my boss comes to me and says, you know, well, you did this, I have in my contract a thing that says I have 30 days to cure, which means from the time I'm notified, I have 30 days in good faith to try and make that right, which means write a formal letter of apology, say I'm sorry, here's a list of things I can do to be better and to avoid this from happening in the future, and then they can't terminate me with that being caused. Like if you stab someone, you can't cure that, but you know what I'm saying. You need to be able to cure these events. Another thing that is super easy to put in that everyone should put in is this idea of termination without cause, which basically means if you decide you don't want to work there anymore, you give them a 60-day notice and you can leave. And normally the default is 60 or 90 days. And that goes both ways. So they can say to you, well, you know, Dr. Webb, we really like you, but it turns out we actually don't have a job here for you anymore. And they can say that the day you get there, and then your 60-day clock starts. Well, Dr. Webb just moved across the country to be there, and now he's got his family there and they bought a house, and that's not equitable in terms of the risk for him and the group on day one. So what I had them do was put in a 1-year moratorium on termination without cause. So they can't terminate me without cause until a year is up, and then they can do the 60-day notice, because I'm more vulnerable in the first year than they are, and it should be equitable. So you just ask them to put that in there. There's no reason for them not to do it and make it equitable. They will look terrible if they don't, and it protects you. You want to know about things like outside activities. Are you allowed to moonlight? Are you allowed to get paid for call? Do they have call pay? Are you allowed to consult for companies? And is that something that they care a lot about? Do they want details? Are they wanting money from that? You need to know that. If you're consulting and spending your time, they shouldn't get a cut of that. And then is there a pathway for partnership if you're in a private group? And what is the pathway? Is that 1 year, 2 years, 5 years? Do they vote? Is there a certain number of cases? You should know all those things before you sign. And then if you're an academic center, what's the pathway to promotion? Super important. If they could tell you all day, oh, you're going to be a professor in 6 years. Well, what does that mean? Do I have to publish this many papers? Do I have to mentor this many residents? How do we document that? What if the chairman who says that to me isn't the chairman anymore by the time I'm ready? You should know what the process is for all of those things to protect your future interests. The last thing that I'll hit on is compensation. Everyone focuses on this first, and that's why I put it at the end. Don't get me wrong, compensation is important, but it is not the most important thing. If you believe that you're going to make a certain amount of money and then you'll be happy, you should look up what the arrival fallacy is, because you're suffering from it. Getting paid for what you do is important, but there's no dollar amount that you're going to get to that's going to make you feel like you made it. That's not how this works. So you need to make sure the money's fair enough for where you're going, and that there's a good ceiling, and that you're compensated for working hard. And some of these things are helpful for that. So you need to know, am I getting a base pay or a guarantee? Again, I could talk a lot about that. And if you guys have questions, I can kind of explain the difference. Is there a teaser rate? And that's like some of the rural hospitals, especially the employment ones, they might say, we're going to pay you $1 million and it's for a year. And then after that, it's eat what you kill. And the implication is you're going to go way above that. And then the second year you make $200,000 because there's no business there. That is a teaser rate. Are you getting a signing bonus? If you're not, ask for one. All these things in these contracts, no matter where you go, it's negotiable. And they can say no, but they can also not say no. So it's worth asking. Are you getting student loan assistance? The first time I asked for some student loan assistance, they said yes. And I realized I should have asked for a bigger number because that's an option. Are you getting a relocation allowance? Like, are they going to give you a few $1,000s to move across the country? Because let me tell you, if you think you're poor now and you're a resident, wait until you get done with fellowship and you just moved across the country and did this, and now you're going to move again and you're selling a house and you're renting for a year. Like, it's really helpful if they help you move. And then, are you getting call pay? If you're a private doc and you're covering a hospital, you probably have a good argument for call pay. If you're not a partner yet in a new group, the question is, are you keeping it? Is it going to the group? Do they make you put it towards your debt pay down, or can you take it out as cash? Like, all questions that matter. It adds up a lot if you're getting call pay and you're taking a frequent amount of call. In addition to that, you should know what is called considerations. Am I taking ortho? Am I doing spine? Am I doing neuro call if I'm a neurosurgeon? And then if you're taking ortho call, how are your partners going to help out? Like, if I get a blown apart distal humerus, am I expected to do that still? Because I don't know if I really want to do that anymore. So you need to talk to the partners about that. Do you have bonus income potential? If you earn above your base pay, you've earned your pay, you've earned your overhead costs, you don't have any more debt to the group, and you make $100 more, what happens to those $100? Does it all go to the group for a certain amount and then you get a split bonus? Do you get 50% of it? Do you get all of it? You got to know where every dollar is going to go before you sign the contract. And then things that we mentioned earlier is like ancillary income potential. Can you buy into a surgery center? Does your group have DME, MRI, PT, CT scanner that they, profit off of and then share amongst the partners? I would say it's equally important to know if they have that. I'm a big proponent in, making sure you have other income streams, but I'm also a really big proponent in making sure you don't go to jail. So make sure that they're doing that legally, which means, like with federal payers, you can't send 10 people to the MRI and then get money back for the 10 people you sent. That's called a kickback. It's a huge violation. You go to jail. So you got to make sure those things are done in a legal way so that you get compensated for investments and things that you own, like you should, but you should educate yourself well enough to know what's right and what's wrong. And then for consulting, like I said, is it allowed? Is it facilitated? Do other guys in the group do it? I really encourage orthopedists to get involved in this because it's a great way to, have your ideas come to life and kind of impact how device companies go and help steer them, and also make income that helps, offset other costs that you have. And you can write off against it if you have a small business that you run the income through. And then the last thing is something that a lot of current spine surgeons are familiar with. It's called the spine tax, is what we call it. Basically means, are you going to a group where they say the overhead here is 60% and everyone pays 60% no matter how much they make? What that ends up meaning is if you make twice as much as the hand surgeon, then you pay twice as much overhead, which means you pay twice as much for the electric bill when you're all using the same amount of electricity. So as I like to point out, unless the hand surgeon operates with only one light in his OR and I need two, that's not fair. So what you really want is a fixed cost if you can get it for the overhead. And then when you earn over that, you're rewarded for the extra money that you make. And a lot of orthopedic groups don't do that. They have a flat rate. You're coming in, and that's why they're recruiting a spine surgeon, is because you're going to contribute more than the average person, and that's their incentive for bringing you on. So, these 10 things I think are super important, at least in my perspective. I'm sure there's other things. It's about asking the right questions. It's about making sure you and your family, if you have one, are going to be comfortable there. And it's about making sure that the group is hiring for the right reasons. Are they bringing in a spine surgeon because of advancing their territory, because someone's retiring, or are they bringing a spine surgeon in because they can't really give you a good answer and they just think spine surgeons make more money? So anyway, worth considering all that stuff. Please type any questions you have for me or Dr. Donnelly, and we'll get to the questions. If you need me at all, here's my contact stuff. Thanks.
Yeah, those were really good talks, and it's things that are not really taught along this path, and that's why I'm so excited about this series here. But I have a question for you, Dr. Burleson. There's a quote out there: 50% of people leave their job in the first 2 years out of training. Why do you think that is?
Yeah, so I think that's a great question. So first of all, for the people out there that aren't maybe aware of this, so I think that's real. That 50%, if it's not dead on, it's very close. I think a lot of it comes down to a misrepresentation or a misunderstanding of expectations. When I've talked to guys that are on their second job, a lot of times it's a complaint like, my ortho call, they told me I'd get one ankle fracture every month, and turns out I was getting 4 cases on call, and they were a bunch of hemis I don't like doing, and hand stuff or hand pus or whatever. And my partners didn't help me at all. And I didn't get block time when I was told I was going to get it. And my clinic, I had to go to 5 different locations. And a lot of it's because they went to dinner and the dinner went well and the partners seemed nice and they didn't get details. I think there's this fear when you're interviewing that if you ask too many questions or ask something too soon, that you're going to come off as someone that they don't like. And the thing that we have to get through our heads as young people interviewing is we bring value to the table. That's why they're interviewing us. But we've been kind of conditioned going through medical school and residency that like it's a privilege that we have a seat at the table. Well, like when you're interviewing for a job, you've earned it. So you need to ask for the things you want. You need to ask for the clarifications that you need. Like when I took my job, they asked about robotics because I did some robotics in fellowship and I think it's really important. And they told me, well, the robot might cost us over $1 million. And I told them like, okay, well, you should probably start saving in your piggy bank because it's a deal breaker for me. I absolutely have to have one. And I only did that because other people encouraged me to stick up for what you want. And you know what happened? We're getting a robot in a month. And it got pushed back because of COVID and all that. But it happened because I said this has to happen. So I think people just aren't clear enough with their expectations and they get there and they think the handshake deal is going to make everything okay. And I would encourage people to remember a verbal contract is worth the paper it is written on. Get it written down, get everything in writing, make sure you get what you want.
Yeah, I totally agree. I think, coming out of fellowship and then going into practice, most people don't know exactly what they're getting into until they're finally there and, working. So I think that's a great answer.
Absolutely. And so Dr. Donnelly, I was curious about your fellowship talk. So, fellowship's still different than finding a job where it's still a rank list and you may or may not get your fellowship choice. What would you say, to someone who didn't get their top fellowship choice? Do you think they'll still be a good spine surgeon?
Yeah, there's a ton of good programs. I think I want to take it personally wherever you match. There's probably 3 people there that wanted to have you a ton, but one other person's voice maybe was more important or more influential. I've been on the other side of seeing how rank lists work for both residency and fellowship, and it's not always what you're hoping it will be. But there's a ton of good programs, and if you go to a program that you thought was great, you'll probably go to one that is also still going to be good. There's a lot of good programs, so I wouldn't really get too hung up on it.
Yeah, I think that's a great point. I think there are many great programs, and you touched on quite a lot of things that can help you sort between them. But in the end, I think it sounds great.
There's a question in the chat box for Dr. Burleson. Any idea about the American Board of Spine Surgery and if it's important for us young surgeons?
Yeah, I think, it's not really a thing yet that matters. It doesn't mean that it won't. I kind of agree with what Dr. Donnelly said about the accreditation stuff earlier. We're behind kind of the sports people and the hand guys about like having their certification. The hand surgeons can get certified in hand and then not recertify in ortho if they choose and kind of just do their specialty. We don't really have that yet. So like, is it going to hurt you to get board certified in that? No, it's not going to hurt you. But right now there's no objective way that benefits you that I know of. So, like we talked about in my fellowship, us being accredited because in the future, accreditation might matter and it might work towards something like that. So I don't think it hurts in that regard. Of course, he mentioned there's things you can and can't do. But being certified, is probably not a bad thing in the way that he's asking there. I just, I don't know a ton about it. I don't know that it's really going to take off.
So I see a question in the chat box. It's asking if you go to a program that's maybe missing something you're hoping for, what do you give advice to? I think there's a unique time period. So almost all fellowships finish July 31st, and then most jobs start usually September 1 or October 1. So you actually have like a month or two time period. And if getting like if you want to do some endoscopic spine surgery, which isn't as prominent in orthopedic spine training versus neurospine training for various reasons, like if that's something that's important to you and you want to do something like that, you can find resources out there. Actually, a lot of your device companies will help be conduits for that. And they can help get you with the surgeon, get you credentials, and you can spend 2 to 3 weeks with someone. I mean, you don't need to spend a whole another 6 months doing something, but really if you just get another 10 cases under your belt in that field, that's a way. So you have like usually 2 months. If that's a need you see, you can also just ask your job to push back your start date for 1 month or something like that. Or they can even pay you half your salary for that 1 month early. Don't work that 1 month, then just recoup it on the end by not getting paid your full salary that last month of your job. So you can just push back your start date maybe a month, and that's a way you can go to a place to do a couple extra 2 weeks of MIS or 2 weeks of deformity. And that's just a way to get a little more supplementation. I don't think you need to do a couple months extra.
Yeah, and I'll add to that too. I think one thing I didn't recognize, because I was at a very tight program for residency in terms of what we could and couldn't do, fellowship, and then after fellowship, you know, if a device company wants to pay for you to go do a course and they're paying so that they can advertise their product to you and try and get you to use it, I mean, I think that's fine if you're trying to learn something new. And during fellowship is a great time too. Your mentors know that you're trying to learn. So if there's something you want to do more of that maybe they don't have, you just tell them, hey, there's this course in a month and they're doing this for a weekend or for 3 days, and get as much hands-on as you can. And most programs will find a way to make that work for you.
Yeah, I definitely agree, Dr. Burleson. You know, going back to kind of your talk about the practice models, there's lots of different practice models out there. I'm in a private practice with about 10 spine surgeons. So if there's something that I wasn't comfortable with or didn't gain exposure during the fellowship, you know, out in practice, just operating with your senior partners, that's been an invaluable experience for me. It's just operating with my senior guys and doing cases with them. So if you didn't see something during fellowship, there's still opportunities once you're out in practice to gain some exposure and gain some more experience. So.
Absolutely. And I'd say something I didn't think much about is I got a couple cases I've done up here with a spine guy that's my age that's in a competing group. Like he's on the north side of Nashville. I'm on the south side, like in the Brentwood area. And I was doing a big case and I was like, it'd be nice to have another set of hands. And I have a spine partner, but he came out of a program that did some similar things. And I was like, you know, like, great. Like he'll come assist me on some case. He'll collect his minimal assist fee because he's also an orthopedic surgeon, and I'll return the favor next month. And so it's, you know, if we're in a collegial environment like we are, it's just about learning and taking care of the patient well. And, you know, that's something that is not off the table either. And that's kind of how I've adapted to that, because I don't have built in what you have.
And a question for Dr. Donnelly. When we were applying for residency, it was this whole kind of thought process that you should apply to as many programs as possible. So I think I applied to maybe 80 something programs. Is that the same kind of thought process when applying for fellowship? How many fellowship programs should you apply to?
I think I would apply to a bunch. Can't think of an exact. No, I think for interviewing, I think interviewing at like 11 or 12 is a good sweet spot in terms of how many you need to see. It's definitely not the same as residency. In terms of programs, I don't know if it's like 20 or 30 in terms of applying to, but I think in terms of the interviews you accept, going to 10, 11, 12, 13, kind of right around that area, or else you're kind of wasting money. One of the advantages of going to some programs maybe you're not as excited about is you get to meet some of these really cool attendings that you maybe otherwise wouldn't meet. You get to become closer friends with people who are extremely likely going to match also, and you get to kind of develop your network a little more. And people, like, the only reason I know John really is from the interview trail, both from residency and fellowship. And it wasn't for us taking a bunch of interviews and going to these things and doing the socials and hanging out. You really get to make friends just from these interview days.
Yeah, and there's some questions in the chat about, do you think that holds true during virtual interviews as well? Or do you think advice for this virtual year is a little different? It's hard to say.
Yeah, I think it's tough. One of the best ways to learn about a fellowship is talking to those current fellows. They really don't have too much skin in the game. They're proud of their own program, but they're also going to shoot you straight. And the attendings usually don't know some of the answers you're going to ask in terms of like case volume and stuff like that. The attendings probably don't know that answer. How much deformity do you do? The attendings also probably have a different idea of what the answer is. The best advice for what a fellowship is like is like those downtimes where you're in the conference room talking to those current fellows and just asking them questions off the cuff very informally. So I don't know how they're doing it this year. I don't know if there's like a Zoom where that format can still go on. But I also, if you really like a program and if a fellow is passionate about their program, I feel like it shouldn't be an awkward thing to just call that fellow one day and be like, hey man, on the way home, can you just call me? I just want to ask you a couple questions. And really there should be an expectation from the current fellows right now that those calls could happen. They should give out their cell phone number and just say, hey, call me. I'm not going to report back. And I told people that if you asked me questions, even if I thought it was a stupid question, I could go tell Vaquero or Hillebrand, they'd be like, I don't care. We're still going to take that person. So don't worry about asking a dumb question or a smart question because it's really important for you.
And there's a question.
I think you make some great points.
Asking if more than one resident in the same class is going into spine, like in this case, 3 or 4 people, any pros or cons to applying to the same program, or should they apply completely independently? So I'll tell you, the fellows at my fellowship right now, there's multiple fellows there that were from the same residency program. I mean, I guess the way I look at it is, if you're a baller, you're a baller. It doesn't really matter if your co-fellow is or your co-resident is too. Like, great. I don't think the fellowships are going to say, well, we've met our quota for UCSD residents this year. Like, that's not a thing. They're going to try and take the best people they can get because it serves them the best to have the best people. So I think you apply where you want to. If it's virtual, I don't know. I guess I don't know anything about the cost. You obviously don't have to travel, so that's the biggest part of the cost. So maybe you apply to more programs and you guys all just do your interviews on different days. But in theory, the cost would be significantly less. I don't know about you guys. I spent several thousand, going everywhere.
I think in terms of if you have 2 of you from the same program, and if you're like, well, only one of us is going to get into that program, they're definitely not going to take 2. Okay, that might be true, but they might not interview either of you. So I think both people should interview. You guys, both guys and girls should try. And, I kind of somewhat agree with you, John, but I know from just my one experience with one fellowship, they were like, well, we have 2 people applying for this place. We're only going to interview 1. And I agree. They might be missing 2 great candidates and take a lesser candidate. So it probably isn't great, but at the end of the day, kind of like it sucks to suck. Like they're going to take the better person, hopefully, and hopefully it's you. So.
Hey, they got one more question here for you, Dr. Donnelly. They said, when looking at fellowship, what do you feel is more important? Fellow autonomy, like at a place that does all open surgery, or exposure to newer technologies like MIS laterals, tubular stuff?
I think fellow autonomy. I think doing the more, I think volume is key. There's when I was at Rothman, the Jefferson residents actually got a ton of spine exposure. They were like the PGY5s were better than I was like 2 or 3 months into my spine fellowship. And so when I talk to people maybe from my home program where we didn't have as much spine, I say you need to go to a place that's high in volume. If I was talking to someone who was an Emory resident or a Jefferson resident who they get really good spine training in residency, I would say, you know what, maybe you can go to a place that's more deformity heavy, that you do fewer cases, but you see some more weird pathologies. So kind of just knowing your own training. If you got a lot of spine experience and you feel very comfortable in spine, then volume's not as important for you. But I think for the most part, most residency programs, you don't get to do as much spine autonomy as you'd like. So go to a place that's high in volume and get a lot of quantity of cases.
Yeah, I definitely agree. I think it's better to kind of learn from big open cases than kind of learn from MIS or smaller cases and then work backwards. Because you may go to a hospital in the middle of nowhere that doesn't have a robot or doesn't have any navigation. So I think it's important to kind of learn from open, learning your anatomy really well, so that when you're out by yourself or in some hospital that has no type of technology, that you're equipped for that. So, but
yeah, and many people say that, we were talking about vendors before, that if you have all of your open techniques down solidly, it's easier to add on like a 2-week MIS course than it is a 2-week open surgery course if you don't know the open surgery basics.
Yep.
Cool.
All right, everyone, it's been great.
All right, guys.
For coming to look.
Promo for next week. Come back.